Let us start the session. Good afternoon to all. Warm welcome to the TIPSECO session. So today's session on difficult pain. Today's session is also handled by Dr. Rajagopal sir.
Hello everybody, good afternoon.
Good afternoon, sir.
Good afternoon, sir.
We talked in the previous sessions about management of pain. We gave the ladder. Let me start with a question. Suppose we take only cancer pain. If we apply the ladder properly, can we take care of all cancer pains effectively? Can we relieve cancer pain so as to give reasonable pain relief by application of the ladder for close to 100,000 patients? Let us take a vote. What do you think? Anybody, any comments? No comments, so let me give you some bad news. Even after application of the ladder, though that gives satisfactory pain relief in the majority of patients, up to 1/4 of people may not get pain relief that is satisfactory to them. Our target is never or almost never total pain relief. We are only trying to bring the pain down to a level that the person considers satisfactory. And that can be achieved only in about 3/4 of the patients with the usual application of the ladder. And we will have these two studies, which are fairly old. Maybe there are more recent studies. Tell me if you come across something more recent, please share it. So that's the problem. Today's discussion is about that other 24 to 29% of patients who do not get reasonable pain relief with the application of the ladder. And my first step, we are going to talk about 10 steps. These 10 steps have no formal authority. It is not as if they are the 10 steps of WHO or anything. I like to take responsibility for those 10 steps. It is not written in stone. It is flexible. But I believe the first step should be accepting that when the patient says, I still have pain, we start by believing them. I repeat this because as physicians, when we are unable to solve a problem, we may get defensive and our subconscious mind may start telling us, hey, is that person really in pain? He cannot be in pain. That I have seen repeatedly happening. It happened to me at one time. So let us start by applying it firmly in our mind that pain, what is pain? Hey, what is pain? Who's going to tell me what's pain? Please raise your hand. I don't necessarily want the whole of the IASP definition. Vijay, what is pain to you? What is pain?
Pain is what is hurting me. It's like it might be emotional, social.
Well, okay, fine, absolutely. Okay, Vijay. But I'll add, by the IASP definition's early part, it is a sensory and emotional experience. And that emotional experience can be assessed only by the person who is going through the pain. That is behind this simple no-nonsense definition, which says, if the patient says it hurts, that's pain. So we start by believing the patient that the pain is not that quickly relieved. And because the majority of people here are not oncologists, or possibly no one is an oncologist, we will have to remember that we have a limitation. We may miss some point if we keep on taking the ladder to the patient and do not think about palliative radiotherapy in somebody with a bone pain, or in palliative chemotherapy in somebody with an obvious ovarian tumor, then we are doing a disservice to the patient. So we'll have to keep thinking, am I missing something? Is there a correctable factor that can be corrected? Third, you have given the prescription. You are not administering it into the patient. And especially in this country where patients are very often scared of doctors, even if they do not take the medicine, they may not come and volunteer the information. So if your treatment does not get the desired effect, one obvious thing is for us to check if I am the patient whether I am taking the medicine as advised. You have given me morphine, an antiemetic, and a laxative and paracetamol. Am I really taking all that? Part of the problem is that I may feel uncomfortable in my tummy. I may feel some nausea, and I just stop taking the tablet. I come back to you, but I am scared to tell you I am not taking the tablet. Especially if you are asking, have you taken the tablets? You know, in that heavy voice that we doctors sometimes use. Are you taking the tablets properly? The patient may say, yes, sir, or yes, madam, yes, doctor. So, checking adherence to treatment must be done in a non-threatening way. So, I don't know what you came here expecting, whether high-flown interventional pain management was what you expected, I don't know. But these are simple things that we must practice every day. If the patient has pain, connect with pain relief, I'll ask the person, okay, have you been able to take the tablets as I advised? For example, these tablets, okay. When do you take the first dose in the morning? Second dose? Third? Fourth? Fifth? How much are you taking in the at night? And when you ask like that, they will say, I am taking it as you advise, doctor. I take one in the morning, one at noon, one in the evening, and one at night. Very clearly, they have not understood that it is 4 early. Instead, they are taking 4 times a day. This frequently happens. And then you find that the tablets that they have in the bag tells you that they have not taken the paracetamol. So the question that you are asking should be, hey, why didn't you take the tablets? That's a little challenging question. I would never phrase it that way. If you say, why didn't you take the tablets, they may immediately feel threatened and they may say, well, I will take the tablets. Instead, say, if you did not take the tablets, there must be a good reason for it. It's a difficult to take. Did it give you some side effects? Not at all. Put in the question in a non-challenging manner. So first step, relieve the patient about the pain. Second,
Correct.
correct the correctable things. And thank you, Vajan. And third, check whether the person is adhering to your prescription. If not, be prepared to find out why and change your prescription rather than scolding the patient. Now, in the matter of affordability, most of you or many of you may not be able to dispense free medicines to patients. You may be just giving prescriptions. Remember that unaffordability is a major reason for poor adherence to treatment. They simply do not have enough money. Or sometimes they may have to take a decision. Shall I take the tablet or shall I feed my child? This is the truth in our country. And remember the cost factor. I think your SIMS is a good tool to have. Between the two formulations of same medicine, enormous price differences are there very often. And the screen tells you how much the cost varies. Immediately, morphine in Kerala is very inexpensive. For most of you, when you are buying from several manufacturers, it costs 5 times as much I know. Maybe shall I give you some homework? Wherever you are working, find out how much morphine costs. Immediately morphine, 10 minutes. Okay? Just find out. It's an important thing. So we are going to step 4. We should look for emotional factors. We said that pain is a sensory and emotional experience. And understandably, major emotional issues can affect the pain. Therefore, look for emotional factors contributing to worsening of the pain experience. Shall I quickly tell you a story? I had this patient with cancer of the breast with supraclavicular lymph nodes, with pain both in the chest and with the brachial plexopathy causing pain. She would never take the tablet properly. Once I sat down and everybody was keeping on advising her, take it at 5, taking it in the morning, taking it at 10 o'clock, etc., etc. She would never come. When she takes the tablets, we also know that she has pain relief, but she still remains in pain through most of it. So I sat down with her and asked the same question. I asked, if you are not taking the tablets, there must be a good reason for it. Tell me what it is. She said, I don't have a watch, so I can't tell them. So I said, this was in the patient's home. I saw a clock in your drawing room. Can we take it from there and hang it up in front of you so that you will be able to tell the time? And she told me, I don't like looking at the clock. I don't like looking at the clock. So you have already had a session on communication. Tell me, how would you react to that? Who's going to volunteer an answer?
Maybe she's feeling anxious regarding the time. Maybe she knows her disease progression and prognosis. There's something going in her mind.
Yes, very good. Yeah, but how are you going to react to that statement? What's your question or your statement in response to that statement that I don't like looking at the clock? Okay, I will help you.
I would ask.
Yes. Yes, Vajja.
I would try ask her saying that what is that troubling you when you look at the clock?
Exactly.
Do you want to share it with me?
Exactly. So I asked, why don't you like looking at the clock? The clock tells me that time is passing by. That conversation took me next step. We are feeling that no, we had not discussed the end of life with her. She was thinking that I am going to die. My children are going to be motherless. I don't know if my husband will remarry. I wonder whether my stepmother will trouble them. These were the thoughts that were going through our mind. Unless we bring them out, there will be no solution. The solution partly was her sister-in-law giving her a promise that already I am looking after your children along with my children. I will continue to look after them like my own children. That was the treatment necessary for relieving her pain. After 3 or 4 days of soul searching, he started taking the medication. Okay, that's an example about how an emotional issue can affect the patient's pain in several ways. Does anybody have a comment or a question?
Sir, in the sorry, sir. Sir,
Oh, yes. Who is speaking? Gina. Go.
so this is also, sir. So in the initial classes, we discussed that if the patient already has some anxiety, it heightens the sensation of pain.
Yes.
So, the patient
Exactly.
is not slept. That gate, sir, that sensation.
Gina, can I ask you to switch off your video? Your voice is breaking.
Okay, sir.
Now try asking the question. Let us see if we can hear you.
So this is the fact that anxiety or even sleeplessness can heighten the pain sensation. That is with relation to this, sir, or even
Exactly.
that also will have.
Exactly.
Yes, sir.
I mean, the anxiety or depression of sleeplessness can heighten the pain sensation, but in this case, pain experience, but in this case, it was also interfering with the medication. So it can affect in several ways.
Okay, sir.
Thank you. So remember, so far, we were only reviewing the situation, believing the patient about the pain, looking for emotional factors, looking for alternative treatment, etc., etc. But now, before going into any other treatment, we are going to review our treatment again. I had given her, or whoever had given her, morphine, paracetamol, antiemetic for the first few days, and then a laxative. And she was now saying that more than the chest pain, the pain down her arm was troubling her more. Understandably, there is a neuropathic pain. I had to treat it. So, with what shall I treat it? These are things that we must think about. We have tried one thing, maybe that's not enough. Is there a neuropathic component? We will have to think about that. Or is there even a bony lesion there, a rib infiltration? I may fiddle with the actual measure. Sometimes, if I think that the compression of the bracket plexus is causing it, I might consider a corticosteroid. So we will think 1, 2, 3, 4. These are the analysis measures you are using. Can we manipulate any of them to get better pain relief? And particularly in the context of neuropathic pain, especially in India, I suppose in any country, there is always a tendency for us to use the most expensive medicines. Not deliberately, because who is the youngest doctor here? Tina or Gina? Let me ask you. We asked the question on another day. Has any medical representative ever come to you and talked to you about amitriptyline? Has any medical representative come and talk to you about gabapentin or pregabalin? Yes.
No, sir.
Usually, the industry industry's representatives talk only about the expensive medicines. So that's on top of our mind. And they will give you evidence in the form of papers, publications, which support their arguments. So, one of the measures of social support in palliative care is making sure that we do not use needlessly expensive medication. For example, there are a series of papers, including a very recent paper which I will come to. And this is a meta-analysis, not one study. At the end of it, synthesizing the recommendations from several meta-analyses, the authors have recommended tricyclics as a first-line medicine in the majority of neuropathic pains, of course with exceptions, and your gabapentin or duloxetine or pregabalin come only as the second step. And specifically in diabetic neuropathy, they have put in duloxetine as a first-line medicine, and even there, pregabalin comes only as a second line. Now, this doesn't mean that it's always like that. Some people may not tolerate tricyclics and we may have to try another thing. But then again, that is true in the case. That's true in the case of other medicines also. So I have got a message which says that the audio is not of good quality. Is that a problem for everybody? Are you unable to hear me properly? Please raise your hands if you can hear me properly. Those who can hear me properly, please raise your arm. Many arms are not going up for either. Please raise your arms if you are not able to hear me properly. Vajja, are you able to hear me properly? Okay, obviously they are not able to hear me. Would you like to fix the fan
So
on?
we are able to hear properly, sir.
But not everybody.
Okay.
Let me see. Let me see if I can make it better. Is this any better now? Dr. Ma? Who is speaking? Whose problem was that? Okay. To share our sorrow, the air conditioning is not working. It's a very stuffy, windowless room. We had the electric fan on, but that was possibly the cause of the problem. So I have been speaking for half an hour without any of you hearing me properly. Thank you for mentioning that. Now I should have checked. Okay. Now, among the adjuvants, especially in neuropathic pain that is not easily treated, this may be one option. That is, in a neuropathic pain that is not easily treated by your usual adjuvant measures, a trial of lignocaine may be a possibility. Now, the anesthetists among you, Tina. Okay, I mean, how about my audio now? Dr. Harpreet, can you hear me?
Yes.
Is this any better now?
Yes.
Okay. Now you see the dosage schedule on the screen. Now again, that's not written in stone. It does not necessarily have to be this way. There can be other dosage schedules, but this is a trial. So suppose you find that your amitriptyline or pregabalin or whatever had not helped adequately, and then you find that there is a significant improvement in lignocaine. It's not easy to keep somebody on a lignocaine infusion forever. So what can be done? Can you think of any medicine that is useful in neuropathic pains that belongs to the same class as lignocaine? Any oral medication? Please raise your arm, anybody who can give an answer. Try an answer. Have you heard of the anti-arrhythmic agent called flecainide? Flecainide. Flecanaide. Flecainide is an anti-arrhythmic agent. Remember, both lignocaine and flecainide. We don't have mexiletine in this country now. Both lignocaine and flecainide, the mechanism of action is that thing that we may loosely describe as a membrane stabilization, preventing abnormal impulse generation within the nervous system. So those who respond to lignocaine may respond well to flecainide. It is not everybody. It's worth a try. We do it. We do give that try. So far I have been still on. Yes, Vajan.
Sir, there was a voice break when you're talking about flecainide. Can you repeat that, sir? Flecainide and lignocaine.
Yes, I can. So I was saying that when the patient does respond to lignocaine, which tells us that we use flecainide. Okay. When it does work, lignocaine causes pain relief by membrane stabilization, that is prevention of or reduction in abnormal impulse generation in the nervous system. And flecainide is the oral medicine which can be given over the long term in such patients. It is only a few patients that really will need it and benefit from it. I was asking Bellamy whether she uses it. She uses another anti-arrhythmic agent called mexiletine, which was available in India, but which is no longer available now. And the next step, 6. We may have thought about interventions earlier, but if nothing else is working, will we consider an interventional procedure? Will you contact interventional pain physician in your town, in your neighborhood, and ask him, hey, I have this difficult pain problem. Is there something you can do? Maybe we'll talk more about it at the case presentation. And also review non-pharmacological measures. Sometimes some pains, particularly when it is muscular and urgent, may be significantly helped by massage. There are several pains which may be helped by transcutaneous electrical nerve stimulation. So you must think about that also. And interventional pain physicians are sometimes also used to employing more of non-pharmacological measures. Okay. You can see the screen. Please read it and respond to me. Any comments about this? So in step 3, there was a time when we had practically only morphine. Then fentanyl came into the market, but it's fearfully expensive. But another relatively inexpensive medicine is now in the market, that is methadone. I would encourage you to study methadone and get it and use it after studying how methadone is to be used. I mean, the reason is the side effect profile of methadone is not as good as morphine. So all of us during the last few months were going through the phase of learning this new medicine that has come into the Indian market. So if you are a beginner, don't straight away start methadone without consulting somebody. By all means, contact us. We have experts here, like Telemi, who has used a lot of methadone, or doctors in Hyderabad Regional Cancer Center or in the All India Institute have been using it already. So there are friends who may be able to help you. So some people who get some pain relief with morphine, but then you increase the dose and they are going delirious or drowsy. That's the kind of person who may do better with methadone. So, is there a question there? So, switching from morphine to methadone or fentanyl is usually considered when the patient does not seem to get adequate pain relief with morphine, and when increasing the dose of morphine causes unacceptable side effects or toxicity, particularly neurotoxicity. Good news, we are already on step 7, there are only 10 steps. Here's a question for you. How many people say yes? Raise your hands, those who think yes. How many? I can see only 4 people. How many people say no? 4, not us. You know what nota is, of course. Oh, if you don't know what nota is, you have a lot of homework about political science coming up. So shall I take that all 6 I can see are notas? Not answering yes or no? Yes. Okay. The answer is yes. Let me explain why I say that. Morphine in the body, you know that it gets metabolized in the liver. Okay? It gets metabolized in the liver to several metabolites, particularly morphine 3 glucuronide and morphine 6 glucuronide and several others. It is suspected that some of the side effects are caused by some of these metabolites. It's not very clear whether it's M6G that causes it or M3G. A lot of arguments are going on, but we are not sure. But now think, if it is the hepatic metabolite of morphine that causes the unacceptable side effects like neurotoxicity, what difference can a parenteral administration, say intravenous, make? How will it help?
Bypassing first pass metabolism.
Exactly, Gina, thank you. By giving it parenterally, the first pass metabolism, that is from the stomach, it has to pass through the liver. That process will be so much less when you are giving it directly to the bloodstream. So the concentration of the metabolites, some of the metabolites may be less, and we actually see this happening. Sometimes when oral morphine does not work, when the patient is in the hospital, we put them on an infusion of morphine, and that seems to help. Sometimes, it is not everybody, but some people get excellent pain relief with parenteral morphine, then they simply cannot tolerate morphine. Now, the nature of the metabolism is also genetically dependent. Some people produce one metabolite more than another because of your genetic predisposition. So, if that is happening, you have 2 courses of action there. If you have methadone, that's one possibility, cheaper possibility. If the patient is an in-house patient, an infusion of morphine may be advisable. Now, Indian Association of Palliative Care has a position statement which says that providing palliative care medicines for patients' administration by the patient and family at home is an acceptable practice. There is nothing legally saying yes or no, but I have used it in patients' homes. But let me give you a word of caution. This is not textbook knowledge, this is our practice. We do not give full ampules to patients, just to make sure that there is no diversion. Instead, we would fill a syringe up so that 1 ml is 1 required dose. So it's diluted in that way, and give the syringe to the family, asking them to give 1 ml every 4 hours. So a 20 ml syringe will last for 2 days or a little more. They are asked to come back thereafter and collect another syringe. We are almost near the close. Step 9. But to go to step 9, let me refresh your memory about the process called central sensitization or wind-up. On one end of the screen, you can see on this side of the screen, you can see the nociceptor, and the peripheral nerve which takes the electrical impulse to the dorsal horn of the spinal cord, where with continued pain impulses, continued unrelieved pain, the process of central sensitization is supposed to be mediated by several neurotransmitters, including N-methane-D aspartate, NMDA. Once the central sensitization has happened, the modification, the pain will be increased in magnitude and also in quality. For example, if today, the first day, 1 impulse going from the periphery causes 1 impulse to go onward from the dorsal horn to the brain, after a week of central sensitization, for every 1 impulse going from here, there may be 10 impulses going from the dorsal horn. So it can keep on rising. And we do not have the time to go into those details, but if we have time in the end, I am glad to explain. The quality of pain also can change with that process, resulting in abnormal impulses, abnormal sensations in the area of pain. That touch being perceived as pain. What do you call it? Allodynia. So if NMDA is causing the problem, the obvious answer is an NMDA antagonist. Who can give me coffee juice? Who can give me the name of an NMDA antagonist? Tina, you are going to give me a name?
The fluoxetine.
Sorry, Tina, louder.
Fluoxetine.
Tina, there is a rule here. You must be very correct, but I would prefer answers that I know. You are taking it beyond my level. I don't know what that is. You are not. Maybe you are quite right. I mean, maybe later, Tina, you will give me the name of the drug so that I can look it up. There are many NMDA blockers, but the most effective that we commonly use. See what's wrong now. You cannot move this. Go only through the. Close it up. Okay. The commonest drug is the anesthetic agent, ketamine. Yes, ketamine. But then you don't use the anesthetic doses. The other drugs, we earlier talked about two step 3 opioids other than morphine. Which were they? Gina.
Fentanyl and methadone.
And methadone. Of course, methadone is a drug which is supposed to be significant NMDA blockade. But your cough syrup, dextromethorphan, an opioid that is used in cough syrups, that also is believed to an NMDA blockade. But being the most powerful and effective one, ketamine is most often used. Hina, you must later tell me or email me what is the name of the medicine that you mentioned so that I can look it up. And particularly in our country, where very often we have to treat difficult pain in the home setting, oral ketamine may be used. It is believed to be even more effective than parenteral ketamine because norketamine, which is generated by first-pass metabolism, actually seems to make the medicine more potent. So here is one dose schedule suggested. It does not have to be that. Remember that most formulations of ketamine, injectable ketamine, are bitter. So what we usually do, there was some talk about oral ketamine being available as a syrup, but I have not seen it. Maybe it is. But what we do is take the injectable drug out of the vial, mix it with a very sweet drink like tea or coffee or fruit juice, and give it to the patient. So as you can see, very small doses are used. Say for example, the dose for a 50 kg person, maybe just 0.2, 0.1 would be 0.5, 1 to 2 milligrams. No, 2 to 10 milligrams may be the dose that is employed. That is given about 6 to 8 hourly. And don't depend on me for the maths. You can work it out with your calculator. So it has a limited place. It is not as if ketamine is something that you use every day. It's a drug with significant, poor margin of safety. So if you use ketamine, better unless you are familiar with the medicine, especially in the earlier days, please call us so that we can guide you or call somebody with more experience in the use of ketamine. So today I've told you about two medicines, particularly methadone and ketamine, where you had better seek experienced people's opinion and advice to be able to use it and relieve the pain. You know that we here like getting those calls and queries. We like it if we can be useful. So don't hesitate to ask. But you must remember that there can be potential problems. Ketamine, something that we did not know even 5 years back, is that it can cause significant hepatotoxicity. So when I put somebody on ketamine, I check SGPT to start with and keep checking it every 3 days. If it seems to be rising, we have no option but to stop it. Similarly, something that we did not know, that it can cause a very severe burning micturition, which is not related to infection. Culture remains sterile, but there seems to be something like a chemical cystitis that is happening. And we are advised to stop it immediately if that happens, because longer term continuation of that drug can cause irreversible cystitis, chemical cystitis. So with ketamine, in addition to the usually quoted numerous side effects, these two are particularly to be remembered. These can be long-term side effects. And with that, I'll stop with the 10th step. Vaja.
So ketamine IV, sir, do we give it at home or at the hospital setup? So because IV, when we are giving, we need to monitor blood pressure also, sir.
Yes and no. Vaja. We are not, yes, Vaja has made an important point. Ketamine can increase the blood pressure, ketamine can increase the heart rate. Therefore, somebody with an ischemic heart disease can be particularly bad. Having said all that, Vaja, the dose here is so small that usually no significant hypertension is seen. Having said that, usually we give injectable ketamine only in the hospital setting. If we have to send the patient home, there is no reason to continue it like that. We can easily put them on oral ketamine. Okay, so we have gone through the 9 steps. Unfortunately, be prepared for some bad news. I am breaking some bad news. So I am giving you a warning shot, so that you don't go into shock. In spite of all this, there will be a significant number of patients in whom you cannot relieve the pain satisfactorily, even with all this. And therefore, that's my first 10th step. Accept. Accept that Dr. Somaraju is only a human being. Dr. Jagadish is only a human being. Dr. Harita is only a human being. We cannot solve all problems. I openly admitted to patients, like I'll always remember one patient, Patu, to whom I started the conversation. I said, Patu, I know that I have done so many things. I know that still I have not relieved your pain satisfactorily. You know what Patu said? Patu grabbed my arm. Just don't tell me that I cannot come back here. Don't tell me that I cannot come back here. I want to come back here. So we are then a walking stick that the patient can walk with. We are fellow travelers. Once we accept that we have failed and we openly talk about it to the patient, then we do not have to reject them. I told Patu, no, you must come back. Because the medicines that we gave you have slightly reduced your pain. So we will continue that. And again, if there is any worsening in between, then also we may be able to help. So Patu, you must come back to us. So the final thing is we accept that we cannot always succeed and we do not reject patients. And in an end-of-life situation, if there is agonizing pain, then we have the choice of a palliative sedation, which is not the subject for today. Already done? That will come up later. So with that, I stop the presentation. We'll take about 10 minutes for any discussion on this. Then we'll go on to Dr. Nisho's case presentation. Who is the opening batsman? Please raise your hand with a question.
Hello,
Who is speaking?
Dr. Harpreet.
Yes, Dr. Harpreet.
Sir, can you tell us about the role of oxycodone tablet? It's not
Okay.
available in India, I think, but outside abroad it's available.
Thank you for the question. Oxycodone is a drug like morphine. Delamy, if Dr. Harpreet asks me any more questions about oxycodone, I will not know the answer. You must come and help. So I think in our step 7, we said opioid switch. Switch over from morphine to another drug. In most countries, oxycodone is the drug that they switch over to. And in many countries, many institutions, people start with oxycodone. No, this is not knowledge. I have this suspicion that oxycodone becomes the first choice mainly because it is sold so aggressively by the healthcare industry. But I leave Delamy to answer that question. So oxycodone is another step 3 opioid, and oxycontin, the sustained release of opioid, sustained release oxycodone, is involved in most of the current adverse publicity in USA about abuse, diversion of prescription opioids. So there is a lot of arguments. Industry is very keen to bring it to India, but we went on arguing for methadone instead because it has other benefits and because it's inexpensive. So, in short, Dr. Harpreet, oxycodone is a more expensive alternative to morphine. Delamy?
So in New Zealand, where we have easy access to both morphine and oxycodone, oxycodone would be used first line in those patients with moderate renal impairment. So it is a little better for those patients. Although in India, that is managed perfectly well with morphine at a reduced dose and frequency. So it is not a huge loss, really, that you do not have oxycodone. Methadone is certainly our go-to for difficult pain.
Thank you. Any other question? Shiva, presentation. Any other question? Any question? So a quick review. Step 1, believe the patient about the pain. Wait a minute. Screen sharing. Believe the patient about the pain. Correct incorrectable factor. Check adherence to treatment. Check for emotional factors contributing to the pain experience. Review the treatment regime, particularly keeping in mind the choice of the nature of the pain and the choice of adjuvants. And next step, review the role for interventions and non-pharmacological measures. Consider opioid switch from morphine to methadone in the Indian context, most probably. Consider alternate route of administration like intravenous or subcutaneous. Subcutaneous or intravenous. Subcutaneous first is what I'll mention. And consider central sensitization and therefore use of ketamine, either parenterally in the hospital setting or orally in the home setting. And finally, when you cannot treat the pain effectively, the best thing is to openly admit it to the patient offer that you will be there for continued support in other ways and not reject the patient. Thank you. Now I have here with me my colleague. Have you ever appeared on the echo screen? Whatever. So this is Nishu. Dr. Nishu is one of our 6 or 7, I have forgotten, palliative care doctors in our team. Dr. Nishu is going to present a patient story to you.
Good evening to all. Am I audible to everybody?
Yes, ma'am.
Okay, so this is a story of one of our patients. Unfortunately, he is not with us right now. So this is the story of the patient. He is a 45-year-old man suffering from carcinoma, pancreas with liver and skull mets. He came with severe abdominal pain of a pain score of 10 by 10. He had other symptoms associated with the pain like constipation, vomiting, and he was evaluated in a nearby hospital. And he was under treatment for Helicobacter pylori, and he was referred from gastrosurgery to us for pain. Okay, so this is what the pain distribution was when the patient presented to us. He was mainly having pain over the epigastric region. Okay, so he was having abdominal pain for 6 months, which got aggravated since last 1.5 months. The pain was pricking type in quality deep inside the abdomen. It was continuous kind of pain, and he was given tramadol 50 milligrams 3 times a day and paracetamol 500 milligrams 8:30, with which he was having pain control but pain relief, but it was only for 1 or 2 hours. But since last 1 month, his pain was severe and he was scoring it as 10 by 10. He was not able to sleep due to the pain, and he was sitting most of the time due to the pain. He was not able to take food, was not able to walk, and sometimes he used to substantiate that taking food increases his pain.
Nishu, can I ask, was his pain only in the abdomen, in the front of the abdomen, or did he have back pain also?
He was mainly complaining of epigastric pain. He said there wasn't any radiation to the back.
Okay.
On examination, his vitals were stable, and on per abdomen examination, he was having tenderness, maximum tenderness over the epigastric. Pulse sounds were normal, he was conscious oriented, and other systems were all within normal limits. He underwent a lot of other investigations in medical college. He underwent an OGD scopy, which showed a fundal erosion, small ulcer with erosions in the duodenum, ampulla was edematous with erosion. He underwent a CT scan which showed a focal acute necrotizing pancreatitis involving the head of pancreas, and there were focal areas of necrosis. He also had multiple hepatic lesions which was not conclusive whether it was metastatic or infective. He underwent an USG scan which showed a well-defined heterogeneous hyperechoic lesion in the head of pancreas with dilated pancreatic duct, which was suggestive of carcinoma of the head of pancreas. He also underwent histopathological examination of the lymph node, which finally came as metastatic adenocarcinoma. Psychosocial assessment, he lives with his wife and 3 children. All the 3 children are still studying. He was the only breadwinner in the family. He was an auto driver. His wife was also unemployed, and though his wife knows about the disease, patient was not aware of the diagnosis, neither aware of the prognosis of the disease. He was financially very poor. This was the initial management. He was on tramadol 50 milligram TID, paracetamol 5 milligram TID, pantoprazole 40 milligram OD, and he was started on continuing infusion in medical college, but patient was not having any satisfactory pain relief. So he was referred to us for pain management. So we can discuss. We can think of other measures of pain management that can help this patient.
Okay, ladies and gentlemen, comments, questions. How will you manage this patient?
Sir,
Who is speaking?
Vajja, sir.
Yes, Vajja.
So here in this case, hello.
We can hear you, Vajja. It's okay.
Sir?
Vajja,
Hello. Yes.
Vajja, we can hear you. Please speak.
Sir, yes, sir. I can hear you, sir. So here in this case, the pain relief, the medicines were given, sir, but the patient doesn't know about the disease. The patient doesn't know about the disease. Initially,
we were okay so far, but now, Vajja, you have gone.
members doesn't want to tell the patient, or any barrier was there, sir?
Once we admitted him with us, we slowly started exploring and we slowly started discussing with him. Then we finally understood that patient had an insight that he is having a serious problem, but he was not very openly talking about it. Then finally, after 3-4 sittings, we spoke to him directly, and then we planned various other methods of pain management after discussing this disease and problem.
So, Nishu, let me ask you a question. So, over 3 or 4 sessions, you conveyed to him that he had advanced cancer, and you also conveyed incurability. How did he react to that?
Actually, we were actually waiting for the HPR report of the lymph node to get a final definitive diagnosis, and we conveyed him that we spoke to the gastroenterologist and we got a confirmation that it is incurable, and we spoke to him that this is going to be difficult and it is not going to be a curable disease, and we spoke to him and we decided what we tried to find out what his insight about the disease and what his insight about the further management or of the treatment he has. So he finally we gave various options of pain management, and he finally understood, and he said he just wants pain relief. So we finally reached a point where he accepted that it's an incurable disease, and pain management is the only mode of treatment that is available for him.
Okay. Did the disclosure of the diagnosis have any effect on the pain? I mean, with all that news going in, did his pain worsen? Did it improve? Was there any effect?
I think his pain worsened because he became very. He used to have. I don't know whether it is right to say he was having panic attacks, but then he used to have difficulty, chest discomfort, breathlessness. He used to have sleepless nights. So what I felt was it was definitely he was not able to cope up with the news, but then he still had an feeling that he might not survive for long. He was worried about his family, his wife, and his children. So definitely that news has increased his symptoms.
So, what's the moral of the story, ladies and gentlemen? Disclosure of diagnosis worsen pain. So, is it good to tell the diagnosis to the patient? Give the bad news and mention the incurability, etc. Can I have some reaction from anyone?
Sir, we follow the same steps that.
Gina.
Go on, Gina.
You follow the steps that we discussed. If the patient, depending on how much the patient wants to know, ask, tell, ask. If the patient is ready for that kind of information, if the patient wants to know, depending on if it will really benefit him from. And once we assess that, I guess we give that kind of information out.
Thank you, Gina. I agree with you, but let me also point out that when you give a bad news, however well you break it, it is still bad. So the emotional distress is going to be considerable on the day of disclosure of the bad news. Usually it will take 2 or 3 days for the person to come to terms with it. So if there is a pain with a significant emotional component, when you give the bad news, it is possible that there may be worsening and you may have to be ready with more medication on that day, whatever that is, including maybe an anxiolytic, a benzodiazepine, in addition to the opioid, or a higher dose of opioid for a day, that may be possible. But usually what will happen is when the patient comes to a state of acceptance, gradually the situation may improve. So good thinking about the emotional factor. Yes, thank you. But in this case, thereafter, the emotional factor was addressed, but significant improvement in pain did not occur, right?
So maybe assurance from the family members also will help, sir.
Absolutely. I mean, like the family's awareness and being supportive is an important possibility. Yes. Yes, I'll agree. You have highlighted the point that an emotional intervention was necessary. It was done. But in this case, despite that, the pain continued to be bad. And also remember that the pain was consistent with the diagnosis. And maybe there was an emotional factor significantly, but very clearly a physical factor was also there. Nishu, when you increase the dose of morphine, if the pain was poorly controlled, why did you not increase the morphine?
He was having side effects with on increasing the dose of morphine. He became more and more delirious.
So we had to reduce the dose of morphine. Bharat, did you have a question?
No, sir. Just I wanted to add to the pain management sequence. We had discussed earlier that WHO step ladder, and so if NSAID is weak, opioids are, and even that fentanyl is not working out, then there is we should intervene for interventive approach, invasive approach in pain management, and for upper GI malignancies, celiac plexus block. Is the next option we can think of.
So, Dr. Bharat is suggesting that, I mean, that was a good sequence in which we proceed. We believed the patient about the pain, etc., etc. And we gave attention to the psychological problem, and still the pain continued. And Dr. Bharat is saying, 766. Step 6, as it is an upper abdominal lesion causing pain, and the pain was predominantly in the low back. Therefore, a celiac plexus blockade, blocking the celiac plexus at the level of T1 around the aorta was a possible solution. In
Sir,
fact, upper abdominal lesions respond better to an intervention, a neurolytic block, than a lower abdominal lesion, because a lower abdominal lesion cannot be so easily tackled. Yes, Dr. Bharat.
sir, this is what I'm suggesting is in addition to ongoing therapy, because
Absolutely.
that will take care of the local pain. But since he is having systemic metastasis, so that we need also to be taken care of, sir.
Absolutely. I mean, like, you do not stop the morphine or other things and go out to celiac plexus block. You continue them, give the block, and if there's a good response, then you gradually slowly withdraw the morphine. That's what you would do. Thank you.
Yes, thank you, sir.
And all other measures have to continue. Yes.
Mm.
Nishu, so would you like to come back? Sorry. രണ്ടുപേരും കൂടി ഇങ്ങ് വരണം അല്ലേ? And would you like to explain how the patient's situation was managed?
Initially, when he came, we started him on, we gave him morphine trial, and he was given 4.5 morphine, 4.5 milligram morphine trial, and his pain score came to 4 by 10. And beyond that, we could not give because he became drowsy. So then we regularized. The next day morning, he said his pain relief is only for 1 or 2 hours. So we started subacute continuous infusion on 15 milligram morphine for 24 hours. But he was not having significant pain relief with that. So finally, we discussed with the patient and we did a celiac plexus block for him. But unfortunately, he was not having next day, though he had pain relief and we could come down on the requirement of morphine, but then he was still having this breathlessness, cough, and other distress, which I think was an emotional distress, which was adding on to the pain which he previously had. So that's how we tried to manage him, but unfortunately his pain relief was not as what we expected.
And what happened finally?
Finally, he was also having symptoms which were suggestive of gastric outlet obstruction. So he was having breathlessness and cough and vomiting, continuous vomiting he was having. We started him on metoclopramide infusion also, but then we could not save him. We could not give a satisfactory pain relief.
And
We lost him.
he died. Okay, on the 30th. Yes. So here was Bharat particularly mentioned. Celiac plexus block may take care of the pain, but does not cure him. All the other problems may still be there. Very unfortunately, this man, though he had good pain relief, started having breathlessness on the same night. Actually, the next day I was thinking of a pneumothorax, so we got him investigated. There was no pneumothorax. I wondered whether there was a hematoma developing. No, there was no hematoma. There was no obvious reason for the severe breathlessness, but he had breathlessness. And unfortunately, the block was successful, but his condition did not improve. His condition worsened, his subacute obstruction worsened, and he died with significant suffering. Okay, that is his story specifically. With celiac plexus blockade, breathlessness is not a usual consequence. And with that kind of thing, actually, because of the sympatholysis, the gastrointestinal motility actually improves. And the subacute obstruction we would have expected to get better because he was already on corticosteroids. But unfortunately, in this case, it was not a success story. Any other question? Somebody mentioned an earlier step in step 5, like reviewing treatment options. Somebody mentioned, I think it was Bharat, mentioned non-steroidal anti-inflammatory drugs. In his case, they could not be tolerated. He was already having a gastrointestinal bleeding because of the malignancy, which we treated with so-called faith and other measures, but he could not go on that. And before going to step 9, we had already given the block and treated the patient. Unfortunately, this is not a success story that we could present, but this is something that we really struggled with about 2 weeks back. And we chose to show this very typical patient with a difficult pain experience. Bellamy, do you have any comments to offer on the whole thing about difficult pain? Come. No, sit.
I just want to add about this particular patient. I guess patients have different types of suffering, and near the end of his life, his emotional, spiritual suffering was the greatest. And we were able to relieve his pain, but we didn't realize such a young man was so close to the end of his life. And I think his spirit knew that, and that's really where his suffering was. And that breathlessness and the anxiety was the way that he went, which was difficult for him and his family, and for us.
Yes, Dr. Somraj.
Sir, good evening, sir.
Yes.
Sir, am I audible, sir?
Yes, please.
Sir, can we think of placing a thoracic epidural catheter at around T12 space and give some kind of epidural fentanyl with xylocaine or bupropion or thing like that, sir, in less dilution, like 0.125% solution instead of celiac plexus block?
Yes. One word answer is yes. Like if we had done an epidural block, we would have had to keep him in the hospital. With a celiac plexus block, we were hoping that if he gets better, we would be able to send him home to live a few days in his own home. That was our intention. So, Dr. Somaraju, absolutely right. If celiac plexus block is not feasible, it may not be. If the adhesions around the tumor are very bad, then the alcohol or phenol will not percolate around the celiac plexus and it may not work. So if that did not work, if that did not give pain relief, an epidural infusion would be an alternative.
And relatively also an easier procedure, sir.
Sorry?
Relatively, it is also an easier procedure for us, sir.
Absolutely. Easier procedure for us. And if you are keeping the patient in the hospital, that's a, I mean, if the life expectancy is expected to be only about 1 or 2 or at the most 3 weeks, it's a good option.
Thank you, sir.
Thank you. For once, we are finishing 7 minutes ahead of schedule. Usually we go on after 5 o'clock. Isn't that great? Any question, comment? We are winding up earlier than scheduled. Okay, ladies and gentlemen, thank you for listening. And if there are no more questions, we'll wind up 7 minutes earlier than scheduled. Isn't that fantastic? So please note down any questions that may crop up in your mind as you think about this, so that we can ask, you can send an email and ask it, and we can clarify it during a subsequent session also. Okay, thank you.
Thank you.
Thank you, sir.